Sir, shall we start? It's 6 o'clock, sir. Or should we wait for some time?
Whenever you like, we can start. I am ready.
Okay, sir.
Whenever you like. If you want to wait, that's fine.
Yes, sir. Just we'll wait for some more time, sir, because
Yeah,
there
sure.
are 15 attendees. Yes.
Yeah, okay.
Okay.
Whenever you like.
Okay, sir. We'll start, sir.
Okay.
Okay. Good evening, everyone. Myself, Dr. Chandrasekhar. I am a Joint Secretary, ISVR. And I also welcome on behalf of our whole executive team. I welcome you all for this wonderful session of masterclass. It's a unique initiative by ISVR to expand our teaching horizon to the remotest areas so that everybody can get helped by these our sessions. And I welcome, without wasting much time, it's my privilege to introduce our master, our past president as well, Dr. Rochan. He's a consultant. He needs no introduction. He's a consultant intervention radiologist at SRHN Reliance Foundation Hospital, Global Hospital, PD Hinduja National Hospital in Mumbai, and Jahangir Hospital and Dinanath Mangeshkar Hospital in Pune. He did his MBBS and MD from AFMC Pune, and he held various positions including MD examiners, professor, PG teacher, and DNB examiners as well. And we will be speaking about the very basics and as well as the advances in the balloon technology, as well as tips and tricks. You will be highlighting all the practical aspects as well. Over to you, sir.
Thank you. It's indeed a privilege to be addressing all of you today. I'll just share my PowerPoint. One second. So we'll keep this simple. And the talk is obviously about angioplasty balloons mostly, but I'll be talking about a little bit about many different kinds of balloons. So to cut a long story short, this was 16th of January 1964, the famous day when the first ever angioplasty was done, endovascular procedure to open out SFA occlusion in Laura Shaw, who had refused an amputation and surgery. Done by, of course, the famous Charles' daughter. And this was an angioplasty. However, this was not done with a balloon catheter. This was done by serial dilatation. From 8 French to 12 French coaxial dilators were used for this dilatation, which was clinically quite successful. And this was the beginning of angioplasty. But then Andreas Brunzig came along and he invented basically the balloon we use even today. The idea for the balloon catheter is not new in that sense, because even Charles' daughter had an idea of a balloon catheter. The difference between between what Andreas Brunzig did and what the people before him did was Brunzig could manage to make a balloon catheter which essentially had a fixed diameter on inflation and could reliably be used at that diameter. So actually, initially, when balloon angioplasty started, you were required to be certified by Schneider, which was the company that Andreas Brunzig worked with, to be able to use one of their balloon catheters. So this was beginning. So this is exactly what, when we talk about balloon angioplasty, we have a stenosis, we cross it and balloon it. You can see the narrowing there in the middle of the balloon, and we get a result like this, which is excellent. And this is balloon angioplasty. However, we all know that it doesn't always work so well. And of course, there are things to be thought about and learned, and there are variations in hardware that we'll be talking about as far as balloon angioplasty is concerned. So I have not put anything on this slide other than to say what happens. So what exactly happens in a balloon angioplasty? So the initial thoughts about this were that balloon angioplasty sort of displaces or compresses the plaque and thereby allows the lumen to be formed, which allows flow of blood. However, the histopathological studies have shown that actually you actually dilate the vessel beyond the point where there is actually a trauma and dissection of not only the intima, but some part of the media and the internal elastic lamina as well, which are both all layers in the arterial wall. So it is a controlled trauma that you aiming to inflict, which leads to the outer diameter of the artery increasing. And obviously, you have to stretch it beyond the point of elastic recoil. If you remember, elastic recoil with any material is the point till which if you place a stress on that material, the material will return to its original shape and size that it had before the stress was placed. So you have to stretch that artery beyond a certain point to get it to stay open, right? So this is basically a traumatic procedure. And this is what happens is that you basically tear the wall of the artery partially without causing a leak to appear, but enabling it to attain a higher diameter than it initially had, right? So there are some terms we use in balloons, which as we go along, we will use and we will define, which includes nominal pressure, rated burst pressure, mean burst pressure, etc., etc. But I want to talk a little bit about Laplace's law, which comes up whenever we use balloons, basically, that as you increase the diameter of the balloon, the pressure it can sustain reduces. Whether it's a soap bubble or a balloon or a sphere made of any given material, as you keep increasing the diameter, the chances of rupture keep increasing. This is important to remember, right? So we will be talking about balloon materials, but first I wanted to start by saying what is the process of doing balloon angioplasty, because each of these steps is relevant to how we should think about the balloon we are going to use or selecting and how the balloon design affects the performance of the balloon, right? So the first requirement is the balloon should be delivered to the site at which you want to use it. That means you should be able to get to the stenosis. And this is achieved by placing the balloon on a shaft of variable length, which is then placed over a guide wire, and that is used to deliver the balloon to the point at which the balloon is going to act. For the balloon to perform this function, it has to cross that narrowing, because usually when you're using a balloon, you're talking about a stenosis or narrowing that you want to dilate. So the balloon has to be able to cross the narrowing that you have, and then the balloon should be able to achieve sufficient force, place a sufficient force on that wall of the vessel when you are dilating to be able to stretch to a point where it assumes a bigger diameter without recoiling or collapsing back, right? And after you have done this, you have to be able to retrieve the balloon. So to meet all these requirements, the balloon has certain design imperatives that have to be met in order for the balloon to function properly, right? So I'll reiterate, you have to deliver the balloon, you have to cross the lesion, you have to dilate with sufficient force to make the lesion respond, and then you have to be able to deflate the balloon, get it to come back to a small size, and then retrieve it out of the patient's body, okay? So anything that goes wrong in any of the steps will lead to a failure of the procedure of balloon angioplasty. Okay. Now, when we talk about this step of the steps that are required, so you can see on the left, there are product attributes which are required for the balloon angioplasty catheter to perform this function. So you have to have enough pushability. That means when you push at the back, which is outside the body, the tip should be able to move forward, right? That's pushability, which requires that the shaft of the balloon catheter should be strong enough that when you push, the tip moves forward instead of just crumpling or collapsing or kinking. Then trackability. That means the balloon catheter shaft should be able to bend enough and not experience too much friction to get around tortuous anatomies that we frequently see in patients. It should be able to go around curves. Or for example, to go around the aortic bifurcation from one iliac to the other without kinking or losing its lumen, which would make it fail in its purpose, right? Beyond that, when you come to crossing, you have to have the lesion entry profile of the balloon. That means the tip taper of the balloon affects how easily you can engage the narrowing. Then the crossing profile determines how much force or how much effort it's going to face and how difficult it's going to be to cross a very narrow site in the vessel. Then the wrapping and re-wrapping, because balloon is meant to inflate to say 6 millimeters, but it's 5 French. So 5 French is less than 2 millimeters, say 1.6 or so millimeters in diameter. So a 1.6 millimeter device becomes 6 millimeters when inflated, and that allows it to cross a narrowing and then force it apart to widen it. But then when you deflate the balloon, it should rewrap to a narrow enough size that you can pull it out of the body into the same guiding catheter or sheath that you used to get it, right? So these are requirements for the purpose of crossing, okay, and retrieval. Then comes radial force and positioning, sizing, inflation. All these are relevant to how well the balloon performs as a device to open up the vessel. Because in a very resistant situation, like say, for example, a venous stenosis, like a chronic iliac vein stenosis or say, a dialysis fistula stenosis, extremely thick wall, extremely fibrotic, you require a lot of pressure, in which case a balloon which only goes up to say 8 atmospheres or 10 atmospheres may not be good enough. You might require a balloon that goes to 24 or 40 atmospheres even. Even then, the lesion may not dilate. So according to the requirement, the demands that you place on the balloon, you have to choose the balloon with the right characteristics. Okay, so that was the point of this. On the right side, you see these sample design goals. So depending on what we want to use the balloon for, the balloon design gets affected, and the designer of the balloon chooses his materials, his shaft design, his profile of the tip, etc., wall thickness of the material which forms the balloon is all chosen to reflect the purpose for which the balloon is designed. Okay. For example, I mean, a very obvious and everyday example, a Conquest 40 balloon, which is a high pressure balloon, is not exactly right for treating a small renal artery stenosis. Okay. Whereas a 6 millimeter monorail balloon is not a great balloon to use in a dialysis fistula situation. So you have to pick your balloon based on the design parameters for the purpose for which you're going to use it. And we'll be talking about this also. Okay. Certain terms that we'll be using. Up on the right, the top thing that we're talking about is, of course, an over-the-wire balloon, as we call it. And the lower balloon is what we call a rapid exchange or a monorail balloon. So the difference between the two is, in an over-the-wire balloon, the shaft is coaxial all the way down. As you can see in the top, there's a cross-section of the balloon shaft, which shows you 2 lumens. One lumen is for the guide wire. One lumen is for inflation and deflation of the balloon by whatever material you choose to use. And this passes all the way down the balloon shaft. However, in a monorail balloon, the guide wire lumen doesn't go all the way down the shaft, but ends pretty close to the balloon in what we call the hypotube and comes out at the side. That means the entire length of the shaft of a monorail balloon or a rapid exchange balloon is not supported by the guide wire. So these are 2 basic designs of balloon shafts that we have. Now, as far as the balloon itself is concerned, there is a working length of the balloon, which is between the 2 radio opaque markers you'll find on most balloons. When the balloon diameter is very small, like say 1.5 millimeter or so, there may be only 1 marker in the middle of the balloon. Now, the working length is which actually assumes the diameter the balloon is supposed to have. Beyond that, and the end of the balloon, there is a tapered part that we call the shoulder. And if you're talking about the nose of the balloon, the taper might be long and slow, and that may be defined by what's called the taper angle or the taper length to allow the balloon to easily get into a narrow space. Okay. So these are the terms that we use for parts of the balloon, and we'll be referring to them as we go along. Okay. Now, the first part, we'll discuss the balloon shaft. What is the balloon shaft required to have? Very easily stated in very simple terms, it has to be kink resistant. When it goes around a corner, it should not get kinked. If it gets kinked, that means it may collapse the balloon lumen, in which case you'll not be able to inflate or deflate the balloon easily. So there has to be kink resistance in the shaft. Then the shaft has to be long enough to get where you want it to go. But supposing you are working with something very close to your access side, then you may not want a very long shaft because that will increase the amount of work you'll have to do, increase the length of guide wire you need to have. So you have to have the shaft available in multiple lengths, right? Then the shaft design, whether over the wire or rapid exchange or monorail. Now, down below, I have put together a table which I think puts together the basic practical points of difference between the over the wire and the rapid exchange design. So the over the wire design has more pushability and trackability because the entire length of the shaft is supported by the guide wire, whichever guide wire you're using. So that adds to the ability of the operator to push the balloon forward and deliver it where it has to be delivered. However, the rapid exchange balloon, as we discussed, does not have guide wire support along its entire length, which leads to a problem of times of the guide of the balloon shaft kinking, where the guide wire is not supporting it. So if you push a monorail balloon too much, it will kink below the hypotube, and then you lose control of the balloon. Okay. Obviously, this over-the-wire design will have more kink resistance as compared to the rapid exchange design, but it will also tend to be bulkier because the entire shaft is a double lumen. So it's of course bigger than a monorail tube along its a monorail shaft along its length. And over-the-wire design will of course need a guide wire which is double the length of the balloon shaft, which means you'll be using a 300 centimeter guide wire for say a 135 centimeter shaft or a 125 centimeter shaft. Whereas a rapid exchange balloon, you can use a 150 or a 180 centimeter length guide wire, depending upon where you have to get. The exchanging process and the number of operators required is more cumbersome with an over-the-wire shaft system. And it's easier with a rapid exchange system. It means a single operator can probably work with a shorter length wire. It's easier for him to deliver whatever it needs to deliver and come out. And now the choice will, of course, depend upon which of these parameters are more relevant to what you are going to do. But supposing, for example, you want to do balloon angioplasty in the carotid, rapid exchange might be good enough because the guide catheter is all the way up, and you may not need that much pushability to cross the balloon, cross the shaft. Whereas if you're dealing with, say, below the knee angioplasty, in that situation, a hypotube would probably not work because, as we know, the tibial arteries tend to be heavily calcified, fibrotic. The occlusions tend to be hard. It may require a lot more pushability to get across. So you will see that almost invariably in angioplasty in the tibial vessels, we tend to use over-the-wire balloons. Whereas for the carotid of, say, even intracranial balloons, we tend to use monorail exchange systems. For the renal, for example, we use monorail systems because the renal is directly a branch of the aorta. So once you've crossed with the hypotube, the origin of the renal artery, there really isn't that much pushability required. So depending on the situation, the shaft type that you're going to use can be selected. And depending upon the kind of anatomy you have, the kind of access size you have, and what attributes you want for your balloon catheter, you need to decide what kind of shaft you're going to use and the shaft length you're going to pick. Okay. Moving on. So based on all this, the catheter shaft materials are basically one of these four. Sometimes mixtures of materials are used, and all these have their own advantages, disadvantages. Not getting to the technical side of it, not really relevant to us because dependent on the balloon, you'll mostly have a shaft which will have the desired properties when you're using the right kind of balloon for your particular procedure. Coming to the balloon. Now, the balloons are of three types: compliant, semi-compliant, and non-compliant. The compliant balloon is actually not usually an angioplasty balloon. It rarely can be used for certain kinds of procedures like say valvuloplasty, etc. And in aortic stent grafts. But a compliant balloon is more often an occlusion balloon rather than a angioplasty balloon. And to show you exactly what I mean, for example, on the left, you see an aortic stent graft procedure where a balloon has been inflated. And this is the coda or a reliant angioplasty balloon used for aortic stent grafts, which is basically a compliant balloon. That means it will not increase it. You can go up in volume, and the diameter is defined by the volume. You can see on the right, for example, this particular chart, which shows volume versus diameter. And in this situation, this is for, I think, a corail balloon catheter. And you can see as the volume increases, the diameter of the balloon keeps increasing, right? So these are used mostly for occlusion purposes, whether the occlusion is carried out in the carotid or in the case of a hepatic vein or all these situations. Sometimes it's used for, say, carrying out the, so pushing the stent graft against the wall of the aorta. So these are the purposes a compliant balloon is normally used for, usually not for a proper angioplasty. Now, then you come to semi-compliant balloon. Now, a semi-compliant balloon is not as soft or as easily inflated to a larger diameter as a compliant balloon is, but the diameter of the balloon does increase as you keep injecting more and more fluid into the balloon. As the pressure inside the balloon rises, the diameter increases, and you usually get a chart. So most commonly used balloons are actually semi-compliant and not completely non-compliant. Any of the commonly used balloons would be falling into this category. And usually you'll have a compliance chart inside the balloon packaging, something like what you see in the center. As you see, a balloon which is meant to be a 3 millimeter diameter balloon. At 6 atmospheres, will achieve 3 millimeters. At 14 atmospheres, which is the pressure, it will be 3.37. So you can see a 0.37 millimeter increase in diameter when you raise the pressure. That makes it a semi-compliant balloon. Now, to explain these terms that we talked about earlier, nominal pressure. A nominal pressure is the pressure at which the balloon is supposed to achieve its intended diameter. So a 6 mm balloon will be 6 mm at, say, 8 atmospheres, or a 3 mm at 6 atmospheres, like that. Rated burst pressure is the pressure below which 99.9% of the balloons manufactured by the manufacturer will not rupture. It's still possible for 0.1% to rupture, but 99.9% will not rupture. Now, these are the two which are usually mentioned in the balloon packaging and the compliance chart. That is the nominal pressure and the rated burst pressure. These are usually mentioned. There's another measurement called the mean burst pressure, the pressure at which 50% of the balloons will rupture. However, this is not usually given out by manufacturers. Semi-compliant balloons are often made up of nylon or mixed thing containing nylon, because you get a soft, more compliant balloon, which still is rigid enough to give you sufficient radial force. Now, one of the properties of a semi-compliant balloon is when you come across a very tight stenosis and you put the balloon across, the balloon will tend to dilate more in areas where the resistance is less, and not tend to dilate enough where the resistance is more. And this is called dog boning, as you can see in the picture you see on the screen. So this dog bone effect means that when you are dilating, say, for example, a very short lesion, which is hard, at the areas where the lesion is not there and the balloon is still overlapping by, say, 2 to 5 millimeters, you may, while increasing the pressure, dilate the balloon to beyond the size that you actually want to, which means the balloon can exert more pressure on the more soft areas of the artery or vessel and not enough pressure in the hard areas or tough areas. So you can actually cause more dissections when you take a semi-compliant balloon to higher pressures, because normal areas of the artery may receive a trauma and an injury that is not supposed to happen when you do it. However, the advantage of the semi-compliant design is that it has better crossability and trackability. So it tends to go around corners easier, and the smaller, tighter lesions can be more easily caused by semi-compliant balloons. They also tend to be smaller in their crossing profiles because they are softer. Now, non-compliant balloons are not supposed to increase in size as the pressure goes up. Of course, there's a limitation to this. There's no perfect material. However, if you say that the semi-compliant balloons normally have a compliance around 10% or so, these will have a compliance around 5% or so. As you can see in the chart, in the curve, as the pressure rises, both compliant and non-compliant balloons do increase in diameter beyond the nominal diameter, but the non-compliant balloon is more rigid and increases in size more slowly. So as you raise the pressure in a non-compliant balloon, the pressure distribution across the balloon tends to be similar. That means the tendency to dog bone is much less with a non-compliant balloon as compared with a compliant or semi-compliant balloon. Okay. So often these are made of PET compound, polyethylene terephthalate, which is a more rigid substance and tougher than nylon and nylon mixtures. And these can provide a higher force for opening a very calcified or hard lesion. But they tend to be slightly bulkier and a little less easy to cross very tight lesions with. And of course, they have less increase in diameter or length on increasing pressure. Right. So what is the effect of balloon on sizing? So if you have a balloon, as you dilate it, there is both increase in diameter and increase in length actually. So there's longitudinal radial growth. So your size that you have picked that you think you're going to affect in the vessel is actually slightly more actually, right? So if you want to dilate a segment of 1 centimeter and you have taken a 1.5 centimeter long balloon, you will actually affect a slightly longer length than you think you do of the vessel because the balloon is going to have both longitudinal and radial increase in diameter. Okay, so the length also increases. Now the issue here is that I'm sorry. Message. Okay. So it has to be remembered that this effect is more with semi-compliant balloons as compared with compliant balloons. Okay. Now, the other factors which are involved in balloon design and which you should consider is the crossing profile. That means for a given rated burst pressure, supposing you have a very hard lesion, you need a higher rated burst pressure, you might have to go for a larger size balloon, but the crossing will become that much more difficult. So you might have to use first a smaller, more compliant balloon to get across, get a little space created, then use a less compliant or a non-compliant balloon to open up the lesion fully. Then this is affected by the thickness of the material that is the balloon wall is made of, and also by the kind of folding that is done for the balloon. So materials which can fold easier like nylon tend to have lower crossing profiles. PET doesn't fold so well, so has a little higher crossing profile. After you have deployed the balloon, how well does the balloon fold? I don't know if you've had this experience, but say a non-compliant balloon like Conquest 40, you can go in very easily through a 6 French sheath or guide cap, guiding sheath. However, when you try to take it out, the 6 French is very tight compared to what it was when it went in. So it doesn't re-wrap as well as perfectly as it was wrapped initially. So the re-wrapping of balloon being affected by its nature means that, for example, if you're going to use a 6 French crossing profile balloon like, say, the Conquest 40, you may want to use a 7 French guiding sheath for it rather than a 6 French sheath because it's easier to pull out the balloon through a 7 French than through a 6 French. 6 French can become pretty tight when you try to take it. Right. Now, the trackability of the balloon is another factor which is affected not only by the balloon design, but by the shaft design. So this varies. And as a general principle, the trackability is better with over-the-wire design, but it's also affected with the shaft materials. The more rigid the shaft materials, the less trackable the balloon is. The more rigid the balloon and the longer the balloon, the less trackable, right? So there is always a trade-off between different properties. To summarize between semi-compliant versus non-compliant balloons, not talking about compliant balloons because that's not really relevant to angioplasty. Semi-compliant balloons will give you better tracking, easier crossing because they're usually low profile, but there are more chances of NH dissection, and really hard and tough lesions may not respond well on angioplasty because you may not be able to dilate the balloon enough, sticking within the rated burst pressure to get enough force on the wall to dilate them. So a non-compliant balloon is much better for tough and calcified lesions, especially if you're only going to do a plain on balloon angioplasty, not placing a stent. And for post-dilatation of a stent which has been placed in a tough calcified area, a non-compliant balloon is always preferred because it won't overdilate the stent when you go up in pressure, right? So this gives you some idea as to how to choose a balloon for the particular purpose. So talking about balloon sizing, the first requirement is, of course, the shaft length should be sufficient for the balloon to reach where you want to go, and the length. So when you are dilating a particular lesion, the lesion length is the determinant of the length of balloon you lead. And as a principle, you should try to avoid multiple dilatations, try to restrict the number of dilatations, because the limitation of balloon angioplasty is dissection, a flow limiting dissection which shuts the artery back down. You minimize that by minimizing the number of dilatations. There are other technologies we'll talk about, and you don't want to injure normal vessel. So you should choose a balloon which is about 2 to 3 millimeters on each side beyond the lesion that you want to angioplasty, right? And you should choose a balloon length that allows you to dilate the entire length as far as possible or practical with just one balloon dilatation, okay? The other part is that as your balloon size decreases, the phenomenon of melon seeding, that means the balloon gets moved and pushed out by an unyielding stenosis because the balloon is too short. So there's always a trade-off between sizing the balloon exactly to the stenosis and achieving sufficient diameter. So with experience, you learn which lesions are going to give you melon seeding, and you know how to deal with it. Increase the length of the balloon, maybe use a bigger balloon, quicker dilatation of the balloon, etc. Lastly, you choose the balloon and size the balloon based on the purpose. If you're doing a pre-dilatation of a lesion prior to stenting, you don't size it to the reference vessel size or the stent size. You size it below that. Usual recommendation is 0.75. But this mainly comes from coronary data. For us, for example, I'm doing an iliac stent with maybe 8 millimeters or maybe even 10 millimeters at times, depending on how big it looks. Self-expanding stent, I'll usually dilate only to 6 mm because the self-expanding stent is able to continue dilatation even after without any balloon angioplasty. The stent will achieve its nominal diameter eventually, right? So depending on the purpose. However, if I'm doing a plain old balloon angioplasty, I would like to use a balloon which will give me maximal target vessel lumen at the end of the procedure as compared to getting a dissection or a vessel rupture. So supposing I am dealing with a 6 millimeter vessel, I think that's the reference vessel diameter. I may use a 6 millimeter balloon and go up in pressure to RBP, taking it to about 6.3 or 6.4, depending on the balloon and how much compliance it has. Or if I'm using a completely non-compliant balloon, I may even use a 6.5 mm balloon straight away, right? So when your target is to place a stent, undersize the balloon to the stent size or the reference vessel size. If your target is plain old balloon angioplasty alone, like in the tibial vessels, you may have to oversize to achieve decent lesion diameter at the end of the dilatation. Okay. So depending on the purpose also, you have to size your balloon. So to summarize, the shaft length of the balloon catheter you're going to use and the design is dictated by the anatomy and the distance from the access site. The length of the balloon and the diameter are dictated by the reference vessel size, length of the lesion, and the purpose for which you're carrying out the dilatation. Okay. A few words about balloon rupture. Now, balloon ruptures are not common events, thankfully, but they do happen as you keep raising the pressure, or sometimes even when you haven't reached the rated burst pressure, balloons can rupture when there is severe calcification or the balloon is damaged to begin with, or because of manufacturer. Now, when there is a pinhole kind of rupture that leads to a jet of high pressure fluid, which can injure the vessel wall, indirectly the vessel wall. The circumferential or radial rupture is the worst because that leads to the balloon folding in a very ugly way. And now the diameter of the balloon is never going to be what it was before the rupture. So retrieving it can become a challenge, and you may have to use, depending on the kind of balloon which is ruptured, you may have to upsize your guiding cath or axis to safely retrieve the balloon, right? There are, of course, balloon retrieval guiding catheters which existed, but right now, perhaps you could consider using an expanding sheath or just upsize the sheath and retrieve the balloon safely without injuring the vessel you have access to. A longitudinal or axial tear is probably the safest kind of tear to have. The balloon leaks, however, does not produce a very high pressure jet, and the balloon tends to rewrap fairly well. And if you're using a guiding cath, it's probably easy to retrieve this kind of rupture in the balloon. And this is the least likely to injure the vessel. Right. So far, I've been talking about the standard angioplasty balloons, but in our when we spoke about the fact that the main limitation of angioplasty is dissection in the vessel wall, there have been attempts over the years to reduce the incidence of these flow limiting dissections, because as IVU studies have showed us, one of the predictive factors for long-term patency, more than the diameter of the vessel that you have angioplasty and achieved, or the presence of a distal pulse, is the presence of dissections in the vessel wall. And vessel walls with more severe dissections, the long-term patency tends to be low. So when we are talking about angioplasty as the primary treatment, it matters whether you have got a dissection or not, or you've got a small dissection or a big dissection or a flow-limiting dissection at that point of time. In many areas, flow-limiting dissection can be treated with stents. In many areas, it's not possible. So these special balloons, a lot of them are designed to deal with the problems that normal balloons cannot handle or don't do well with. And I'll be talking about these now. So the group of cutting and scoring balloons, the aim of these designs is to create a situation whereby there's a more controlled trauma to the vessel wall, to the intima particularly, so that the balloon can, at a lower pressure, deliver a target vessel diameter. It has been seen as you keep increasing the balloon pressure, and as we spoke earlier, the chances of causing a dissection are much higher because the trauma to the vessel wall becomes uncontrolled. Now, these are two different approaches to do a similar thing. One is the flex dome or the Boston Scientific peripheral cutting balloon, which has actual blades on the balloon wall. And these blades cut into the intima only for a very minimum depth. And that is releasing the stress, uncontrolled stress based on unprotected areas of the vessel wall. And that leads to a better target lumen. And this has been shown in animal studies, in vessels that have been angioplastied and fresh frozen cadavers and studied histopathologically, as well as in clinical trials like the one done for AV fistula angioplasty using cutting balloons. Now, scoring balloons are similar, but they don't actually have blades. They have nitinol wires like running over the surface of the balloon. And these wires, in an angiosculpt balloon or one of these balloons, they do similar things to what the balloon does. Now, one of the tricks that we used to use earlier in a resistant stenosis was to put two guide wires and the balloon along with that, and the guide wires outside the balloon cutting into the vessel wall and the fibrosis to give you a better lumen at the end. Similar thing was done by needling around the vessel with a needle percutaneously where you could, okay, to break the fibrosis. Now, these achieve similar results, and it's been shown that the target vessel diameter achieved at the end of the angioplasty is much better at a lower pressure with this angiosculpt balloons or flex dome balloon, and flow limiting dissections are reduced. The other thing these scoring balloons particularly do is that they fix the balloon in the vessel. So twisting of the vessel on the balloon or slipping of the balloon is much reduced. And that also is thought to minimize the incidence of flow limiting and severe dissections in these vessels when you use these balloons. Now, the other approach that has happened to reduce this uncontrolled trauma to the vessel wall that standard balloons cause is something called a chocolate balloon, which is a Medtronic device, not available in India as far as I know. So what they did was, and this harks back to the original design that Charles' daughter actually made for a balloon, which was to put a cage around the balloon so the balloon could not expand beyond that point, right? And as the balloon expanded, the cage kept opening out till it reached its end. So with this balloon, it has a nitinol frame around the balloon. When the balloon is inflated, it reaches the point at which the nitinol frame cannot expand anymore. So the balloon forms a series of, one can say, high stress points and low stress points. So where the pillows of the balloon expand beyond the frame, there is more stress placed on the vessel wall, and in the grooves in between, the stress is low. So there is a lot of stress relief. So the injury that happens does not propagate across the vessel wall. So if dissections do happen, they're limited and small. And this has been shown with both, again, animal studies, cadaveric studies, and in human beings that these balloons do achieve their aim. That is, the incidence of flow limiting dissections is much less with these balloons. So these pillows and these nitinol constraining structures, pillows and groove design apparently does lead to a better result and a better long-term patency in plain old balloon angioplasty. So this is hardly a plain old balloon. This is certainly a simple balloon angioplasty, not aiming to put a stent. These designs do help. The latest kid on the block is, of course, the lithotripsy balloon, and a little bit extra about this. So the idea of this balloon came from the technology of extracorporeal shockwave lithotripsy. However, the ESWL is a technology that aims a number of ultrasound beams at a specific calcification, that's a stone, and aims to pulverize that stone. Whereas the IVL is not a focused beam, but an unfocused beam. And the aim of this is not to pulverize the calcium in the vessel wall, but just to cause multiple fractures. So this is designed quite differently from the ESWL device. So basically, you have inside the balloon, you have emitters. There can be 4 to 5 emitters in a peripheral balloon, depending on the length the balloon has. Okay. So basically, the steps in the intravascular lithotripsy are to place the balloon across the stenosis. You have to cross the stenosis to use the balloon. After you have crossed with the balloon, you inflate to 4 atmospheres with a mixture of 50% saline and contrast. And then there is the emitter spark gap discharge, which produces these cavitation waves, ultrasonic waves, that are transmitted radially from the balloon length. And these multiple shock waves disrupt the calcium in the wall. after you have, so this is usually done at one emission per second kind of frequency. And then after you have achieved this thing, and each balloon is good for say 150 emissions, and the balloon is then inflated to 6 atmospheres to achieve the target vessel size that you want while the fractures are still fresh. And that is the end of it. Now, this, I believe, is extremely effective. And why this is so, and why it doesn't cause tissue trauma is a question that was raised initially. For example, when you have ESWL, which is the red line that you see here, you get positive waves and you also get negative waves. And that amount of energy transferred is a lot in a very short time. Whereas with the IVL system, the amount of energy transferred is low and there is no negative pressure. So this reduced peak pressure minimizes chances of getting any tissue trauma. Okay. So local heating, for example, can happen with ultrasound. If there is enough ultrasound energy transferred to tissue, that can cause tissue trauma. But the energy levels here are so low that they don't cause any tissue trauma. Whereas the calcium, which absorbs the maximum amount of energy from here, does get fractured. This is borne out by this kind of studies that were done. Above, you can see the severe calcification in a vessel wall, and below, you can see the microfractures caused by IVL, intravascular balloon lithotripsy. These fractures allow us to dilate the vessel now without facing the extreme resistance of calcium that we feel otherwise, and without using too high a pressure to dilate the artery. The next group of balloons that we can talk about are drug-coated balloons. Obviously, one of the limitations of angioplasty from the beginning and of stenting has been the restenotic process that happens because of vessel wall injury. And this is mediated by the inflammatory response to the trauma and the smooth vessel cell division and thickening and conversion. So drugs for inhibiting cell division were used to inhibit this process of vessel wall response to injury, right? And the two drugs that were commonly used for this, which initially started with drug-eluting stents, which are now pretty old technology, were paclitaxel and sirolimus. They are quite different in how they work, and these are, but both of them basically inhibit cell division. The other part that drug-coated balloons needed was to have a delivery mechanism for these chemicals to not be given to the entire body. Paclitaxel, for example, is also used in treating certain kind of cancers and as an immunosuppressant. So you have to reduce the systemic spread of these drugs because that can be a problem. You want them to be restricted to local, delivery, increase the local absorption, and you want to preserve the drug on the surface of the balloon till it is used. So mechanisms for these were developed. So when you talk about paclitaxel coating, so this is a lipophilic drug, which of course that means it easily crosses cell membranes and gets delivered to cells locally. But you do have to use an excipient, which is the kind of a coating on the balloon to keep the drug localized in that area and deliver it and increase its absorption. The problem with paclitaxel is that in animal models and other areas, and even with certain histopathological studies, shows that paclitaxel does cause certain amount of localized inflammation and even necrosis in cells. So there is certain amount of cytotoxicity that paclitaxel has. So to reduce, so that's why the whole controversy about paclitaxel eluting balloons and all-cause mortality and all this. It seems that the population-based studies don't bear out that increase in mortality population by certain studies. Now, this is the list of currently available, and I'm sure there are more have been added since this list was made to the paclitaxel eluting drug-coated balloons, which are available. Almost all companies have them, and it's very popular right now. But basically, what you will see in this excipient, there are various kinds of excipients, and all of them have their proponents, their problems, their advantages. But suffice to say, there is no clear superiority of any one design over the other. They will say the paclitaxel dose delivered in the area is higher or lower, depending on the manufacturer. But clinically speaking, it's not as if anything has shown a clear superiority over the other. Now, the other drug is sirolimus, and sirolimus coated balloons have been a problem because sirolimus, unlike paclitaxel, is rather more difficult to deliver locally. So it has a lower tissue bioavailability. So, but it does have the advantages. It's not a cytotoxic drug, but a cytostatic drug. That means it does not cause localized inflammation or necrosis. and therefore has reduced vascular toxicity. So it has always been a goal, and there have been new technologies developed, as you can see here, to deliver sirolimus as the drug at the local area. So there are these three which I know of. Some of them use very advanced technology, nano molecules-based delivery of drug. Some of them have reservoirs on the surface of the balloon which deliver the drug when they are brought into contact with the vascular tissue and the balloon is inflated. To sum it up, these balloons have their role. It's clinically not very obvious that we should use them in all patients, some patients, but certainly there's one area. If you've got a patient who has restenosis inside a stent, or a patient who has wall thickening in a given area, this might be the best balloon to use. However, the data is not yet so good that we can recommend these for all patients. And of course, they have a cost and they have a small shelf life. So these balloons come with complications. Right? So that is it from my side about balloon angioplasty catheters. And if there are any questions, I'll be happy to answer them. Whatever.
Thank you, sir, for your wonderful lecture. Let us look for any questions from the audiences.
Thank you.
Sir, if none, then I will ask a few questions from my side.
Yeah, please.
Okay. So how do you say the balloon angioplasty is technically successful? Is there any objective criteria?
So there are two answers to this question, in the sense that one is a long-term answer and one is obviously a short-term answer. So when we talk about technical success, we're talking about immediate angiographic result. So in general terms, you say an angioplasty is successful when the residual stenosis is less than 30%. This is all given in the books. But a clinical success is something else. That means your target is achieved of causing a wound healing or reducing an organ damage or improving an organ function in one way or the other. So there are three things which I would look at to say that my angioplasty is good when you're talking about plain balloon angioplasty. One is that I have a set diameter that has been achieved by the artery. Two, there are no flow limiting dissections in the field. Three, there is no thrombus in the area. If these three things are met, then I will say the procedure is done and I get out. If dissection or thrombosis is present, I may have to either monitor the patient for some more time on the table or do something more to take away the problem, which is compromising my result. I hope that answers the question.
Yes, sir. What I heard from, what I read from the book, there are three criteria. One is the arterial lumen after PTI has less than 30% residual.
Correct. That is the usual definition of technical.
Second, number two is arterial, the luminal diameter is at least more than 50% of pre-treatment level.
Which is same thing as the other in a different way.
Third is
what you can
pressure gradient. Pressure gradient less than 30.
But ultimately, none of these are completely under your control. Sometimes you'll have to accept a result which you can get, depending on the tools you have available. However, until you achieve a desired diameter, which is a target diameter, which you should aim for before you started the procedure, depending on the area you are in, you should continue a balloon angioplasty. If you're not getting the desired result, what you'll do is the question, which then comes up. So supposing you have an artery where you want to achieve a 3 millimeter diameter, and after you did the first angioplasty with the 3 millimeter balloon, you got a recoil. And now the artery is only about 1.5 or 2 millimeters, which frequently happens, as you know, in chronically closed atherosclerotic arteries. So what will you do next? So now there are two ways of approaching this. One is to try a different technology, which could be atherectomy or a stent, depending on whether you can do it in that area. Assuming that you cannot stent and you have to only stick with angioplasty. Then the next step is to either use a different kind of angioplasty, means use one of the different balloons like cutting balloon angioplasty, etc., or you use a larger balloon. Now, this is always fraught with peril because as you upsize the balloon, there is a point at which you will get arterial rupture. But usually speaking, up till 1.15 times the diameter of the artery, you can usually go without causing a rupture to the artery. But of course, that presumes that the arterial wall is not so diseased that it just gives way. So I would say that my criteria would be based on One is what is my target diameter that I started out with, which I'll accept. Maybe in some cases, I would do a pressure gradient. However, the problem with doing a pressure gradient is you have to use a pressure wire to get a pressure gradient, because a pullback gradient is frequently a problem, particularly in smaller arteries. The act of putting a catheter across the narrowing will change your gradient. So if you manage to lower the gradient and you manage to get a pulse back in a case of peripheral arterial disease where there was no pulse before, these are reasonable indicators that you achieved reasonable technical success. So all the definitions that we have of 30%, etc., these are based on things which you can't easily quantify in the clinical setting. So I would use criteria like achieving pulse, getting a flow which is not showing any flow restriction, having a target diameter achieved, and no dissection in the area that I'm looking at. Okay,
yes, sir.
And no thrombus. If
Sir,
any of these are present, I think I need to carry on and achieve a better result. I need to improve.
And what dilution of the contrast we need to have while inflating the balloons? Dilution is
right. So there is no clear-cut study on this. The thing is, there are two things required from the contrast that you put into the balloon. One, it should be well seen. So if you are in a certain area with a very small balloon, you might need to use more concentrated contrast just to see the balloon is dilated or not dilated, right? Second is the time of inflation and deflation. The more concentration of contrast you put in, the more time it takes to inflate and deflate the balloon. That may have clinical consequences because you want a rapid inflation and a rapid deflation, so that during the period of inflation, whatever obstruction to flow is occurring is minimized, right? At the same time, dilating the contrast too much may make visibility a problem. So as a general rule, you don't go below 50% for small balloons. But for large balloons, like say you're doing a 15 millimeter or a 20 millimeter angioplasty, as we sometimes do, you can use much more dilute contrast because these large balloons at that diameter are more easily seen even with dilute contrast.
And regarding with some in vulnerable plot, supposing there is a concept of when you inflate the balloon while removing, you should have a counterclockwise removal. Yeah, I mean, what is your...
So regarding balloon inflation, deflation, there are studies and there are theories about this, that, and the other. But the fact is, it is the only strong data regarding technique of balloon angioplasty is in support of two things. One, you should inflate slowly, giving it a little time to achieve full diameter, not keep increasing the pressure because the balloon is not fully inflating and the neck is still there. Take your time over it. Don't try to suddenly inflate the balloon. That is more likely to cause a dissection. Second part is when you deflate also, do it slowly, not suddenly. The third thing is the data is there across number of studies, which are mostly cardiac studies, coronary studies, and some are peripheral arterial studies, that inflation of 60 seconds and more correlates better with long-term patency in plain old balloon angioplasty. So if you're just going to do an angioplasty, inflate the balloon slowly, keep it inflated, take your time over inflating, take your time over deflating, do it slowly, and keep the balloon inflated for 60 seconds or longer. For example, we do it in TBLs, we do it for 2 minutes. We keep the balloon inflated for 2 minutes. Take it up, keep it up for 2 minutes, then slowly deflate. Slowly reduce the pressure, because rapid deflation can also give rise to a more extensive dissection.
And is there any difference in the inflation between arterial and venous angioplasties? I mean, timing. Because one attendee has raised the question, how long we should supposed to inflate the balloon?
So if you are doing a venous angioplasty, I presume, if you're talking about central venous stenosis, for example, where you're trying to avoid a stenting, wherever you're going to place a stent, it doesn't matter. Inflate to a diameter, place your stent, and you can post-dilate, no problem. If you're using a stent graft, even easier. Less chances of dissection, rupture, etc. But if you don't want to use a stent and you're trying to get the maximum possible gain, especially in a venous stenosis, it is not an atherosclerotic plaque that you are opening up. It is fibrotic tissue. And the tissue has a higher elastic modulus than your average plaque or arterial wall. So you need to give it more time to expand. The more rapidly you try to inflate, the more the chances are you'll cause a leak. So take it slow, give it time. Now, the problem with this is a lot of times the patient will experience pain. particularly in the area where you are at the point below the clavicle where the brachial plexus is right next to the vein. If you're dealing with a situation like that, you may want to consider GA or a local block to reduce the pain, but do the inflation slowly and the deflation slowly. The third thing is, if you're doing a venous inflation with a balloon, usually we'll be using a non-compliant balloon like the Conquest or one of those balloons. These balloons tend to have very long shoulders, and they usually come in a limited size in terms of length. So you usually have only a 40 mm balloon. So if you've got a longish area, it is not a bad idea to first use a cutting balloon or a scoring balloon if you can get it, and go to say 6 to 7 millimeters, then use your high pressure large balloon. So a 2-level inflation is not a bad idea in this situation, tends to cause less problems and gets you a better lumen at the end of it. Right. So I tend to, when just doing angioplasty, is to be very conservative and increase the balloon size that I'm going to in steps. You can use one single balloon and go up in pressure to the target diameter. What that will do is it will make the vessel wall stretch much more and the trauma will be more uncontrolled. Whereas if you do it stretched, give it recovery time in the middle, you may end up with a better result than you would with a single balloon. So when your aim is to get the best possible diameter at the end, with the least likelihood of a lot of dissection and having to use a stent because you got a flow limiting dissection, then you would start up with small dilatation, and if you can afford it, patient can afford it, sculpting or a scoring balloon initially is a good idea, particularly in venous stenosis where it's very fibrotic. To then stage your dilatation to the maximum or target size that you want to achieve. Okay, and do it slowly. The faster you do it, the more chance is there of an uncontrolled injury because the vessel gets no relief time to adapt. So you're more likely to get a deeper tear if you do a sudden inflation than if you do a slow inflation.
Okay, sir.
Does that answer the question?
Yes, sir. Hand inflation versus inflation device, pros and cons.
Right. So, I mean, it's easier to much easier and much more relaxed to do it with an inflation device than by hand. Hand inflation, frankly, if you are actually doing a true balloon angioplasty, there are limitations. But prior to the time that we got these high pressure deflators, we used to do a lot of hand inflation. So first we would, because you can achieve a very high pressure with a 1 cc syringe as compared to with a routine indiflator, which only went to 20 atmospheres, you can get 30 atmospheres there, and there are studies for this. So the advantage of the indiflator is it's much easier on your hands or your assistant hands, whoever is doing the inflation. Secondly, you get a much controlled rate of inflation and deflation. So if you're doing a true balloon angioplasty and not pre-dilating for a stent, I would recommend using indiflators, particularly now that high pressure ones have become available.
Okay. In few points, like in a hand inflation, inflate with a smaller syringe, that is like a 1 cc or 10 ml Luer lock system.
So you get a higher pressure, the smaller the syringe.
Yes.
The smaller the syringe, the higher the pressure.
Yes, sir. While deflating, you can use the 20 ml or larger.
Yeah, larger syringe, more suction. So if you want more suction, use a large syringe. You want more pressure, use a small syringe.
Yes, sir.
And if you can get a polycarbonate syringe, that's better than a PET syringe. You'll find it easier to manage.
And do you use urographene or ioaxal for balloon inflation, sir? That is question.
So I tend to use the same contrast that I'm using. So if the balloon rupture does happen, the contrast will get into the vessel. It is, if the balloon rupture doesn't happen, it doesn't matter at all which one you use. The non-ionic contrast tends to be more viscous, so the inflation times are a little longer, but they're not significantly different. So I don't think clinically it matches much which one you use. I would not use, the isosmolar contrast media because they are really viscous.
While deflating, there will be a big problem because it's
yeah, that takes a lot more time. So I would use iohexol, whatever you're using, whatever contrast medium you're using on the patient, use the same. But if you're using an isosmolar contrast media on the patient for some reason, iohexol, I would not use that for balloon inflation because the viscosity is much higher than normal contrast media.
Okay. How much dilation should be aimed for in a narrowed vessel? Any reference or any percentage of oversized?
So you would try to get the vessel, like I said, when I was talking about how to size, if your aim is POBA, plain balloon angioplasty, and not pre-dilatation for stent, you should try to go slightly above the reference vessel diameter with your balloon. Right? That's your target. Because there will be some degree of recoil. And if your target lumen at the end needs to be, say, 7 millimeters, need to go to slightly higher than 70 millimeters to achieve that, which means you go to take a semi-compliant balloon, you'll go up in pressure. If you're taking a non-compliant balloon, you take a balloon which is a little bit larger. If you talk about a 7 millimeter vessel, you might take an 8 millimeter balloon. That really helps you to get a best possible lumen at the end of it. But remember, there's a problem with continually increasing the balloon size. You may have a vessel rupture when the vessel wall is completely non-compliant. It may just tear rather than give up. Okay.
Can you decrease the risk of micro dissections by using a shorter lens and under dilating that too very, very slowly?
See, under dilating, if your aim is to achieve vessel size, should be a preliminary thing. That means you use a smaller balloon, under dilate, see the response, then go to full dilatation. Supposing at a small size balloon, you start getting dissection and rupture, then you use prolonged low pressure dilatation to get rid of that. And that's a different topic. But really speaking, if you're doing angioplasty for the purpose of revascularization, your aim should be to get to a reference vessel diameter. You may or may not achieve it. And often it's a clinical judgment as to what is achievable and what's not achievable. But with the current balloons, you usually can get to it. And you should try to get to it as far as possible. Under dilating is always a compromise. It means that you probably feel that it's not safe to dilate anymore. Now, that's a judgment that you have to make. It's a judgment call. And it's really no criterion which tells you for sure when it's going to rupture. Right? So,
and what's your choice
for territory you're in?
Yes, sir.
Sorry?
What's your choice for renal artery angioplasty and whether stenting is always required? One of the...
That's a much bigger question than the subject we are on.
Yes, sir. Yes, sir.
So we would talk about stent use in different terms.
Yes,
that depends on the disease you're dealing with.
Yes, sir.
It's a complicated question. There's no easy answer for this.
Okay, sir.
But generally speaking, with atherosclerotic osteal lesions, stenting is mainly always required. With vasculitis and with non-osteal lesions in distal small arteries, I would not stent as far as possible. If I have to stent for a flow limiting dissections, if possible, I would use a reabsorbable stent if I can get one. Does that answer the question? Okay, for the time being, at least, and because this is a topic which should come up in a,
yes, sir,
in a different talk, right?
So what is the balloon of choice for central venous stenosis?
As of now, there is only one balloon you can use. I mean, the high pressure Conquest series is the only one, and the Atlas series is the only one you can use for those. There is an option of using two balloons instead of using one big balloon. You use two smaller balloons, but nearly always the results are suboptimal as compared to the balloon of right diameter and right length. So as of now, the only balloon which really fits the criteria with which we have sufficient experience with it is the Conquest, both the Conquest 40 and the Atlas.
Thank you, sir. Actually, it was wonderful discussion and some practical tips which were given by your very...
So I think that probably, I mean, we should have a discussion on the techniques, clinical techniques and all this separately, because really it's not possible to cover everything. But there is just too much information. This was mainly about technical aspects of balloon, general purpose, not specific areas, territories, things like that. That should be discussed in separate talks. Right.
Yes, sir. Thank you, sir, Rochan, sir, for your wonderful lecture. And you can see so many good compliments by the audience. And I request all of you to spread the word of mouth so that this masterclass will be attended by many residents. And these are easily available free of cost in YouTube. You can watch it anytime.
Yeah.
And it's time to wind up.
Yes, if I could recommend one thing, if the topic is coming up, if people have specific questions, they can pre-post it. So then we can, you can email it to Dr. Chandrasekhar or somebody, and we can see if we can cover those issues also in our talks. Because, for me, it takes a little time to remember what it's like to be at that point of time. So I may, not think of something which you may think of as a pertinent question, right?
Yes,
it would be good if you know beforehand. Thank you so much.
Thanks you, sir, for your wonderful session. It's time to wind up. And thank you.
Okay, thanks.